that really opened the door to transplant medicine as a whole. But I want to show this picture because it is historically interesting and also demonstrates some of the complexities of some of the people that were involved in early transplant medicine. And so you'll notice in this laboratory, the walls are all painted black, the tables are black, the floor is black, the gowns are black, the hoods are black, the gloves are black, and all of the sterile drapes are black. And there's a single spotlight that shines down on the field that these two technicians are working on. This all led from a actually rather unfortunate set of beliefs that Dr. Carell had, which is that he was a self-avowed eugenicist who believed that cultures that sprung up in regions of the earth of very high or very low latitude that experienced a lot of darkness during the year, during the winter, those cultures were intellectually superior to cultures that sprung up near the equator, where there was a lot more daylight. And his unfortunate idea was that darkness assisted with focus, and that was what led these cultures at high and low latitudes to be, in his mind, intellectually superior. And so I bring this up because I think it's just important to remember the context that many of these early pioneering physicians were flawed humans. We celebrate the work that he did, and we celebrate the Nobel Prize that he won, but it's important to remember that he was a complex figure, as many of the other surgeons and immunology researchers in this field are going to prove to be. So we're going to start in the early 1900s, where Dr. Carell and his colleague, Dr. Jaboulet, developed some new vascular anastomosis techniques. And this was the work that ultimately won Alexis Carrel his Nobel Prize. Prior to this, the bulk of vascular anastomosis was, it worked well for large vessels, but not so much for small vessels. And there were lots of problems with clotting and bleeding. It was in part Dr. Carell's idea to start using endothelium sparing suturing techniques. In 1902, Dr. Ullmann in Germany performed the first technically successful dog auto transplant, where he excised a dog's own kidney and reimplanted it, and then performed the first dog-to-goat kidney xenotransplant using some older anastomotic techniques that rapidly led to graft failure in both of these animals, but was an important proof of concept surgery. And then in 1906, Dr. Jaboulet attempted a pig-to-human kidney xenotransplant and a second goat-to-human kidney xenotransplant. And both of these patients, unfortunately, died as both of those transplants failed rapidly. In 1909, Dr. Unger in Germany attempted a monkey-to-human kidney xenograft, and this also unfortunately failed and the patient died. Dr. Carell and another one of his colleagues, Dr. Flexner, not the Flexner of the Flexner Report, but a different one, started to open up the field of transplant immunology following some of these early failures, and initially started to experiment with the idea of using whole body radiation desensitization as a way to condition the recipient's immune system. That research that they did in the early 1910s would actually come back a couple of decades later. There was a bit of a lull until the 1930s when a Russian surgeon, Dr. Voronoy, attempted the first human-to-human renal transplant, which failed due to multiple factors. There were, as the field was still relatively new, there were some things that were overlooked that to us are now obvious, but at the time were not so obvious. So for example, this part of the reason that this particular graft failed was that there was a major blood group incompatibility And part of the reason that it failed was that it was a very prolonged warm ischemic time, both of which are things now that we know that we need to control, but at the time were still not widely accepted. He attempted 4 more of these transplants over the coming years, and unfortunately, all of those patients acutely rejected and died shortly after surgery. An interesting side note, Charles Lindbergh actually approached Dr. Carrel in the 1930s about the potential of developing an extracorporeal organ perfusion pump, and the original prototype is pictured on the left here. It's just a neat story. So Charles Lindbergh's sister-in-law had rheumatic fever and had gone into heart failure, and he was asking Dr. Carrel, who was the leading transplant scientist at the time, whether a heart transplant was feasible, which unfortunately at the time was not, but their work together developed the first organ perfusion pump. And that initial prototype that they built never really left the research setting, but it comes back, and we'll see at the end of my slideshow that the idea of extracorporeal organ perfusion has come back in a very big way. Most of the research in the 1930s and into the 40s, as I mentioned earlier, was centered around the idea that acute rejection was antibody mediated, and so there is a heroic search for what this antibody was in the blood, and Jim Dempster and his crew were struggling very hard to find that one single antibody, which it turns out does not exist. Another scientist named Dr. Loeb hypothesized that instead of pure antibody rejection, that maybe organ rejection was due in part to cell-mediated immunity. He, due to research politics of the era, was summarily dismissed, and his research career was ruined, and his idea was rejected for decades, and unfortunately set back transplant immunology for many years. The early 1950s were a hard era for the early transplant surgeons, and this is the time where transplant surgery as a field almost came to an end. In 1951 in France, there were 9 attempts at kidney transplantation. 8 of those grafts immediately after surgery had no meaningful function, and the patients died within the next couple of days. A 9th patient, which was a mother-to-son living transplant, lasted approximately 3 weeks before it was finally rejected, and the patient died. During the same period of time, Dr. Hume at the Brigham Hospital in Boston had also attempted 9 kidney transplants. Only one of them lasted a significant amount of time, which lasted approximately 5 months before it was finally rejected and the patient died. And it was at this time that Jim Dempster wrote that scathing quote that we went over at the beginning of the talk, when he declared that human organ transplantation was impossible and unethical, and that all further efforts should cease. At the same time in Paris, an anonymous physician published in the newspaper this quote that a pitiable young woman had become the needless victim of a needless experiment, which ended in a grave sacrificed on the altar of a surgeon's ambitions. When will our colleagues give up this game of experimenting on human beings? And when will they realize that dying too can be a mercy? There were some self-imposed moratoriums on transplant surgery that were enacted at this point, and many hospitals were closing down their programs. But finally, 2 days before Christmas in 1954, there was success at the Brigham Hospital in Boston, Massachusetts. The first successful human-to-human kidney transplant between identical twins. This was an interesting surgery because while it reignited the passion for transplant medicine in the public eye, and it sort of reignited the research world around it, when you go back and look at the literature that was published immediately around this procedure, most of the transplant medicine community was not actually impressed by this. They their overarching attitude was mostly, well, yeah, of course it worked. They were identical twins. That doesn't solve any of the problems that we're having. But it was such a publicly monumental success that it really gave transplant immunology and transplant medicine as a field the kickstart that it needed to start looking more into immune suppression. This is where some of the original ideas of Alexis Carrel came back with whole body X-ray therapy, and then some further ideas that had some mild success with nitrogen mustard and recipient desensitization, but it wasn't really until the addition of azathioprine to the medical cocktail that we started to have any sort of success with renal transplantation. And then came Dr. Thomas Starzl, who is another one of the grandfathers of transplant medicine, who performed the first liver transplantation and also the first pediatric liver transplantation. It was his idea to add prednisone to azathioprine, which dramatically improved outcomes in renal transplants. And then once the newly discovered cyclosporin was released, he added prednisone to the cyclosporin and really kicked open the doors to non-renal transplantation as a whole. He and his colleagues also went on to investigate an experimental drug called FK506, which turned into what we now know as tacrolimus, which is still one of the gold standard medications for transplant medicine. So the 60s really became the era of transplantation, and we see pretty quickly a lot of different attempts and successes. So in 1963, we had the first successful human-to-human lung transplant in Jackson, Mississippi. 1967, we saw both the first successful human-to-human liver transplantation by Dr. Starzl, who's pictured on the right, and the first human-to-human heart transplantation by Dr. Barnard in South Africa. And then later in 1968, we see the first technically successful combined heart-lung transplant at Texas Children's Hospital in Houston. This is another interesting photograph. This is Dr. Eric Rose of Columbia University performing the first pediatric heart transplant in 1984. This was on a 4-year-old patient who had hypoplastic left heart syndrome. And interestingly and atypically for this early on in the world of transplant medicine, this patient lived long enough to get into medical school, and he actually he unfortunately died 2 weeks after starting medical school, but it was an incredible outcome, and just kind of goes to show that pediatric patients tend to do a little bit better than adult patients do with solid organ transplantation. But we're going to switch gears now a little bit to donor identification and some of the problems specific to pediatrics with donor identification. So organs donated to pediatric patients, the majority of them must be procured from pediatric donors, and this makes sense. There are size mismatch problems, and so for some organs it doesn't matter as much. Kidneys, there's a little bit of work that you can do with fitting them into the abdominal cavity. Liver, you can transplant just a partial lobe of it, but lung and heart sort of need to be appropriately size matched to the recipient. You can imagine an infant with hypoplastic left heart syndrome is probably not going to do well if you try to transplant in a 35-year-old's heart. So there's already an organ shortage amongst adult donors. There is even more of a shortage amongst pediatric donors. And so there has been a lot of research done into what can we do to increase the organ donation pool. Just as a background for people who are not intimately familiar with transplantation, as I was not prior to this talk, donation is generally done in two manners. There's either donation after circulatory death, which is a little complicated in that the patient must undergo cardiac death within 60 minutes of withdrawal of life-sustaining treatment prior to going to harvest of the organs. And the reason for this time window is that the longer you go between withdrawing life support and the patient dying, the higher the risk of hypotension and organ ischemia. And so because of these problems, generally only the kidney, liver, and small bowel are procured in this manner. But liver and small bowel, as they're more sensitive than the kidneys are, have even shorter allowable warm ischemic times. And some transplant centers will even use 20 minutes as a cutoff for those organs and then use 60 minutes for kidneys. Lungs and hearts tend not to do as well historically with donation after cardiac death, although this is changing, which we're going to talk about later on in this talk. So traditionally, lungs and hearts are procured after neurological death, but that is, as we're going to talk about shortly, there are additional challenges and problems with that as well. Another issue with pediatric organ donation has been that there have been historically weight cutoffs placed on who can donate. A lot of hospitals were previously using 10 kilograms as a cutoff for when someone can donate organs, but now some centers, such as Primary Children's Hospital in Salt Lake City, are using 2 kilograms as a cutoff for certain organs, for example, on block kidney procurement. And what that's done is it's actually opened up some of the neonatal population to transplantation, which has helped with the availability of organs. So in a 2-year study at Primary Children's Hospital in Salt Lake City, Dr. Bennett and her colleagues looked at how frequently pediatric patients were being referred appropriately to the organ procurement organizations prior to dying. And they found that up to 23% of potential donors in their hospital were not actually being appropriately reported to the organ procurement organization, and the likelihood of being reported appropriately decreased the younger the patient was. And I think that's an important thing for us to keep in mind, is that we often don't think about it in our young patients, especially in infants and toddlers. We tend to think about it more in adolescent patients or school-age patients, but we have to keep in mind that there is a need for organs in the infant and toddler population as well. And especially for hearts and lungs, they're going to need to be from size-matched individuals. And so it's important for us to remember to continue to report potential donors, regardless of their age, to the organ procurement organization. Some of the additional challenges that they found were that children less than 3 years old are less likely than older children to die within that 60-minute window of withdrawal of life-sustaining care. And that's not particularly surprising, I think, to most pediatricians. Young children tend to have a pretty significant cardiovascular reserve, but it does make the issue of donation after cardiac death a little bit more challenging if we're exceeding that 60-minute window. Another hurdle that this group encountered was that in this 2-year study period, none of the parents of infants between 1 month and 12 months of life actually gave permission for donation of their child's organs after death. That's a hard question to address, is how do we approach families of infants about organ donation? And the simplest answer to that is that, fortunately, that's not entirely our job. That is sort of what the organ procurement organizations really exist for, is to help facilitate that conversation. But it is on us as physicians to remember that even in infants, we should be having that conversation with parents early on if we think that death is a real possibility. This group also found that donation after circulatory death increased the amount of transplantable organs by 42% over this 2-year period. Which, interestingly, our own Dr. Christine Pleacher had published a similar finding I found a couple of years prior while she was doing her fellowship over at Salt Lake City. So I think that's an important thing for us to keep in mind as well, is that while we generally think about in the pediatric population of donation after neurological death, if we open up children to donation after cardiac death, we do increase by a significant amount the amount of transplantable organs. So I am a physiology nerd, which is very unfortunate for all of you because I am now going to talk about physiology, which is everybody's favorite subject. This is just a cool picture of Dr. Starzl, again, helping this gentleman carry a cooler that is presumably full of organs off of an airplane and looking very dramatic while he does it. So we're going to start with challenges of heart and lung procurement. And my interest in this is because these are traditionally the hardest organs to obtain from pediatric patients in particular. And in pediatric donors, lungs are the most frequently compromised organ. And there's a good reason for that, and it's a complicated reason that is hard to address. And so what I'm going to do here is there are two studies that I'm going to go through. One that is going to show what happens to the myocardium during the process of brain death, and another paper showing what happens to the pulmonary vasculature during the process of brain death. And I'm going to summarize them now so that it will hopefully be easier to follow along with what I'm saying with these two papers. And it'll make more sense as we're going through it, and your eyes will spin a little bit less when I start showing you graphs and tables. So maintaining the health of lungs and hearts during neurological death is hard, but it does follow a relatively stereotyped and predictable pattern during the brain death process, and it follows a rostral to caudal progression. So cerebral damage is going to be what happens first. And this cerebral damage is going to lead to an increase in vagal tone and is going to give you the classic vagal symptoms that we're familiar with, which are decreased heart rate, decreased blood pressure, and decreased cardiac output. As the damage progresses down into the midbrain and toward the pons, we start to see increased sympathetic activity in the brain. And then as the brain stem and the medulla are damaged, we lose the parasympathetic nuclei, and that leads to an unopposed sympathetic activity and an unopposed catecholamine surge. And this is what's known as the autonomic storm. So anyone who's not familiar with this, the autonomic storm is a transient hyperdynamic state surrounding brain death where we see an increase in the heart rate, an increase in the blood pressure, increase in systemic vascular resistance. And in a very short period of time, this systemic vascular resistance can actually surge so high that the left ventricular output drops to near zero and can lead to acute myocardial ischemia. That vasoconstriction that happens in the periphery and increases your systemic vascular resistance can then cause increased venous return to the right side of the heart, which then leads to blood pooling in the pulmonary vasculature. And as we'll go into in one of the papers, this is one of the proposed mechanisms behind the idea of neurogenic pulmonary edema. As the damage continues to progress through the brainstem and into the upper spinal cord, eventually the sympathetic nuclei are knocked out, and that heralds the end of the sympathetic storm. The problem after that is then your systemic vascular resistance drops so much and you become so hypotensive that that leads to additional coronary hypoperfusion and further myocardial damage. So now we're going to break this down and show the evidence for why all of this happens. So we're going to talk about a study by Dr. Shivalkar and all. This was done, this is an important study that was done in the early 1990s, actually, but the results still are sort of the crux of why we have problems with getting good functional hearts from brain dead patients. What they found is that in the early 1980s, up to a quarter of transplanted hearts failed for reasons that were completely unrelated to either acute rejection or to infection. For a while, it was it stumped people. They weren't sure what was happening, that once the hearts were transplanted, they were starting to fail. And they started to fail in a fairly predictable pattern. And on histological exam, they were finding that these hearts that failed after brain death were showing a pretty typical pattern of injury that was significant for subendocardial hemorrhage, contraction band necrosis, and a finding called coagulative myocytolysis, which is a term that refers to breakdown of the contractile material inside of the cardiac myocyte, and then leaves the cardiac myocyte unable to squeeze in a coordinated fashion. So this group aimed to study what exactly the hemodynamic effects of brain death are and what those subsequent effects on cardiac function were downstream. And so, as with many physiologic studies, this was unfortunately performed on animals. And so 11 dogs were recruited and voluntold and anesthetized. They were cannulated with arterial blood pressure monitors, intracerebral pressure monitors, left ventricular pressure monitors, and electromagnetic flow meters over the aorta to monitor cardiac output in a continuous fashion. And then they were also connected to, continuous EEG and ECG. Burr holes were drilled into the skull and a Foley catheter was inserted into the intracranial space. And the Foley catheter balloon was then filled with either a bolus of normal saline to simulate an explosive increase in intracranial pressure, or it was filled with a slow continuous infusion of saline to simulate a gradual increase in intracranial pressure. And then at the moment of brain death, or following the moment of brain death, serum catecholamine levels were measured at the 1 minute, 2 minute, 5 minute, and 10 minute intervals. I'm not going to spend a lot of time on this table. The meat of the study is on the graph that we're going to go to next, but just to summarize quickly some of the physiologic results that they found. So in both of these tables, group 1A represents the group of dogs that had the bolus pushed into the catheter balloon, simulating that explosive increase in pressure, and group 1B represents the group that had the gradual increase of intracranial pressure. And none of these particular findings are surprising to us now, but it is nice to have them categorized so neatly like this. And so you can see in both groups, there is a pretty dramatic surge in the heart rate immediately following brain death. In addition, there is a dramatic surge in the mean arterial pressure. Not surprisingly, there was an increase in intracranial pressure, which makes sense that when you fill a balloon inside of the cranium, the pressure inside of the cranium is probably going to increase. What I found particularly interesting was this number here. And so this number is the first derivative of the left ventricular pressure. So if you remember back to your days in calculus, what this means is effectively the instantaneous rate of change in left ventricular pressure. And so what this shows us is that at the moment of brain death and immediately following brain death, there is a dramatic and sudden increase in the left ventricular pressure. And what that leads to is a left-sided drop in cardiac output. Down here, we can see catecholamine concentrations following brain death, and predictably in both groups, both the level of epinephrine and norepinephrine surge, and they surge higher the faster that brain death sets on. What was interesting here is looking at myocardial ischemia versus infarction, and in both groups, while there was a statistically significant change, there was not a whole lot in the way of infarct. It was mostly ischemia that's observed. And so that can be a challenge, because when you're looking at the heart just with your eyes instead of under a microscope, you might not actually see some of this damage. And that is part of the explanation for why early on so many people were running into difficulty with figuring out why these hearts were failing. And it was because of the microscopic damage, not the gross damage that they were seeing upon a procurement of the heart. So This is a little bit of a hard graph to look at, so I'm going to break it down into pieces so it's easier to look at for us. So if you look at this top section here, this is a graph that is going to show us the intracranial pressure here with this solid line, the heart rate here with this dotted line, the mean arterial pressure with this thinner solid line. These shaded areas represent the serum concentration of epinephrine, and these time marks here, 0, 60, 120 minutes, and 180 minutes, represent the points where the bolus of saline was pushed into the Foley catheter balloon. And so you can see with the first bolus, generally there is a transient dip in heart rate, which sort of accompanies that sort of Cushingoid response that we see. But mean arterial pressure stayed relatively constant, if not trending a little bit upwards. But there was not a dramatic surge in serum epinephrine levels. Same thing happens for the second bolus, but then on the third bolus, when brain death is actually established by clinical criteria, there's a massive surge in the heart rate instead of a drop in the heart rate. Transiently, and then the heart rate falls off again. And then similarly, there is a massive surge in mean arterial pressure before it falls back down. And there's a very dramatic surge in the serum epinephrine levels. This graph down on the bottom just goes to show that first derivative of the left ventricular pressure. So it shows, again, a very sudden and dramatic increase in the left-sided pressure specifically. This micrograph on the right is demonstrating the coagulative myocytolysis that we talked about earlier. And so you can see the nice healthy striations of myocardial cells are gone, and you see all of these clumps in here, and that just indicates that the contractile material of the myocyte has died. Interestingly, this does not necessarily mean that these cells are, or this particular region of heart has infarcted. This can all occur just with local ischemic damage. And so some of this damage might not necessarily be seen with the naked eye when you're inspecting the heart grossly. This is the same sort of graph for the second group that simulated a more gradual increase in intracranial pressure. And while the effects are not as dramatic, they do follow the same trend, which is that when brain death is established clinically, very quickly you see a surge in heart rate and mean arterial pressure and an increase in serum catecholamine levels. This micrograph on the right, however, shows that there is quite a bit less in the way of that myocytolysis, and that you have a lot more of the healthy looking striated cardiac myocytes. So these hearts would function a little bit better than their counterparts in the explosive brain death group. Interestingly, upon further research from later studies, there was a conclusion drawn that there may also be a direct cardiotoxic effect of this massive surge in serum catecholamines. And that's going to come up a little bit later. So now we're going to switch to the lungs, which this is a misleading picture because this is a heart, but I'm going to talk about the lungs. This group by Dr. Nowitzki and his colleagues followed a similar protocol. Instead of using dogs, though, they used baboons who they anesthetized and then cannulated according to this diagram. And so they placed a right atrial pressure monitor, they placed a Swan-Ganz catheter to measure the pulmonary artery pressure. They put electromagnetic flow meters on both the main pulmonary artery and the aorta for continuous monitoring of the specifically left-sided output and specifically the right-sided output, and then a left atrial pressure line and an aortic pressure line. And then they followed the same sort of protocol where the Foley catheter was inserted into the burr hole in the skull, and the brain death was induced with either an explosive increase in pressure with a bolus or with gradual increase in pressure with a continuous infusion of saline. And again, I'm going to break down this graph for you because this graph is the crux of why lungs are so fragile and why they are the most frequently compromised organs, even following brain death as opposed to cardiac death. So there are a couple of lines to look at here. So one is this dotted line, which represents the mean arterial pressure. We have this dashed and dotted line, which indicates the systemic vascular resistance. This top solid line here is the cardiac output from the right side of the heart. So the cardiac output going through the main pulmonary artery. And this solid line down here is the cardiac output going through the aorta, so your left ventricular cardiac output. Brain death is established at this time mark here, and it's important to know that this entire graph only lasts 105 seconds, so this is a very transient, brief effect that has very profound effects on pulmonary function and pulmonary injury. And so you can see that at the moment clinical brain death is established, as we saw in the other paper, the mean arterial pressure and the systemic vascular resistance both surge. What is interesting with this is that because this group was able to break out cardiac output by left and right side, they see that the left-sided cardiac output actually plummets during this immediate period. And that makes sense because your systemic vascular resistance increases so high that your left ventricle can no longer squeeze against it. And so in relation to the heart, that means that you now have decreased coronary perfusion. And in regard to the lungs, that means that you now start to have some pooling of blood in the pulmonary vasculature because your left ventricular pressure is so high that it cannot any longer escape the pulmonary bed. At the same time, though, interestingly, the right-sided cardiac output increases, and that's because you have increased venous return with this increase in systemic vascular resistance, and the pulmonary vascular bed is quite stretchy, and so you can fit a lot of blood in there, and it turns out that you can fit 76% of the total blood volume of a baboon inside of the pulmonary vasculature. That's a problem because that amount of blood in such a fixed space is going to exceed the hydrostatic pressure of the pulmonary vasculature, and it's going to lead to massive pulmonary edema and pulmonary injury. This is just the second part of that graph, which is showing the left atrial pressure and the pulmonary artery pressures and the pulmonary vascular resistance over that same period of time. We sort of already discussed what all of that means. So the more important question is, all right, we know that this happens to the lungs and the hearts now, what do we do about it? And the very frustrating answer is there's not a whole lot that you can do about it because the moment of brain death is very hard to predict. We, in a laboratory setting, can know exactly when brain death is going to occur because we are the ones who are going to be pushing the saline bolus into the Foley catheter balloon. In the clinical setting, we can make a rough estimate of when we think brain death is going to happen, but we can't know down to the minute. And unfortunately, this surge in SVR happens on the order of 1 to 2 minutes. And so there's not a lot that you can do either proactively or reactively in that case. And so the name of the game for management really becomes managing hemodynamic compromise that occurs later on down the road. And so most of the treatment is going to come down to normalizing the physiology as much as you can. So shoot for normal blood pressures and strict avoidance of hypotension because you have to perfuse those organs. Minimize the use of epinephrine and norepinephrine because as we showed in that first paper, there may be some direct cardiotoxic effect, and some of the evidence shows that there is actually an independent association of heart graft dysfunction with increased epinephrine, norepinephrine, and dopamine use. Preventing arrhythmias is very important, sinus bradycardia being the most common one, but this can be a little challenging because to use atropine, you are depending on a functioning vagus nerve. And in a brain dead patient, the nucleus of the vagus nerve has been lost, and so atropine may not actually work for you. And so you have to then use the cardiotoxic drugs, epinephrine, dopamine, or even go to transcutaneous pacing. This is such a challenge that up to 25 of potential pediatric donors in particular are actually disqualified from transplantation due to just the hemodynamic compromise that occurs. I'm running short on time, so I'm going to not go into this ethical dilemma that I listed here. I'm just going to tell you briefly about it so you can kind of think about it on your own time. But there is a legal and ethical question about whether cardiac arrest should preclude organ donation in a brain dead patient. And from a medical perspective, the answer is no. Cardiac arrest after brain death does not actually preclude you from organ donation so long as you maintain adequate perfusion. The question is, how do you do that? And is it ethically sound to perform CPR on a brain dead patient, especially if they have a DNR order? Or is it ethically sound to cannulate a brain dead patient for ECMO to try and continue to perfuse those organs? And that is a debate that is still raging right now in the transplant community. I'm going to, just because of time constraints, skip through some more of the details on ICU management, but one important fact that I think is important to keep in mind. We think frequently a lot about severe acidosis as being a contraindication to transplantation, and it is not necessarily. There have been some studies that have shown some actual good functional outcomes with pediatric hearts in particular that were harvested from patients with arterial pHs as low as 6.5. So significant acidosis is not necessarily a contraindication to donation, even for hearts in the pediatric setting in particular. That data has not borne out as well in the adult setting. Gonna very quickly just mention how some of the contraindications have been changing, in that there are now very few absolute contraindications, and they really come down to active extraaxial malignancy and active untreated infection. And just for the sake of time, I'll mention that the question of infection is so long as you have been treating the infection for 24 hours, it is generally okay to transplant through an infection. There are a couple of caveats. For example, influenza usually makes lungs no longer suitable for transplantation, but influenza does not necessarily preclude the rest of the organs from being transplanted so long as the patient has been on Tamiflu for 24 hours. Someone asked me as I was preparing how COVID infection plays into transplant medicine. I'm not even going to talk about it because we don't know, nobody knows yet. And I'm sure there are a lot of people who are working on publishing some low impact papers on that subject as we speak. So with the last couple of minutes, I just want to talk about what some of the evolving technologies are that we're using to try and improve organ yield. And the biggest one is ex vivo perfusion of organs. And so if we go back to that original Carrel-Lindbergh organ perfusion pump almost 100 years ago now, that idea has come back in a big way. So just a couple of reminders. I have no financial conflicts of interest. I did not receive any compensation from the following companies. I just think that organs are cool, and I think these following machines are cool, and I want to talk about them. So one is the new ex vivo XPS, the flexible, comprehensive EVLP platform. This is actually a very cool machine, and so it's recently received FDA pre-market approval. And the idea behind this machine is that there would be a bank of machines at a ex vivo organ perfusion center, and so when an organ is procured, it would be sent to a place where these machines are set up. The organ can be perfused until it can be deemed suitable for transplantation, and then it would be sent off to the recipient site. And so the novel lung perfusion trial involving this setup involved 332 sets of donor lungs. They took 116 of those and transplanted them in the current standard practice. They took 110 lungs that were initially deemed unsuitable for transplant and then hooked them up to the EVLP circuit. and then after perfusing them, reassessed them to see if they were then suitable for transplantation, and found that that group of 110 were suitable for transplantation afterwards and went on to be transplanted into recipient patients. The remainder of the lung sets that had been cannulated on this circuit were still determined to be unsuitable and therefore were not used. But what this trial found was that at the 1-year survival point, there was no statistical significance between groups of recipients who received standard of care acceptable lungs versus lungs that were made to become acceptable on the ex vivo lung perfusion circuit. This is the organ ox Metra, living organs for life. This is specifically for liver transplantation, and it's a similar idea. There's a tank on the right over here that you put the liver into, as this gentleman is doing, non-sterilely into the sterile field with his uncovered watch and without his mask and with his very much not sterile white coat. But there was a randomized study on normothermic preservation of the liver prior to transplantation, in which 220 liver transplants were randomized either to conventional static cold storage, which is putting it in a bucket of ice, or to normothermic preservation using an organox system. And the group found a 50% reduction in graft injury with the normothermic preservation. They found a 50% lower rate of discarding organs. And they found a 54% longer average preservation time of organs after procurement. And they found no significant difference in graft survival, patient survival, or bile duct complications at the 1-year point. And this is the last one I'm going to show you. It's the Transmedic multi-organ platform technology, which comes in 3 flavors. You can get it in lung, heart, or liver. The one I think is the most interesting is, of course, the heart. And so this is just really visually interesting to me because you connect the heart to the circuit, and because you're perfusing it, it starts beating again. The landmark trial behind this particular machine is the OCS Heart Expand trial, in which the group set out to see if you can expand the donor criteria for hearts to make more of them available. So they took 93 hearts with this expanded criteria, which included an ischemic time of over 4 hours, a downtime of greater than 20 minutes, an EF of 40 to 50, a donor age of 55 or older, and even the presence of coronary artery disease. And they found that after ex vivo perfusion on the Transmedic circuit, 75 of those 93 hearts then became acceptable for transplantation, and the 30-day survival of those patients was 94.7%, and the 6-month survival was 88%. It is a little bit lower than the control group, but not statistically significantly different at the 6-month mark. And I have gone just about over time, so I am going to stop there, and I'm going to open up the chat window to see if anybody has left any questions. There are no questions, but Dr. Smith left a very fun fact that those twins that we mentioned from the first successful human-to-human kidney transplantation are actually from Maine. So there's a fun little Maine fact for us for today. So I'm going to leave it at that because I ran right up through my time, and it's now 10 o'clock. Great. Well, thank you all. It's been great. Thank you for coming to my TED Talk, and hope you guys all have a great day.
Nice job, Kyle. I know it's weird to not get feedback, but lots of people, I don't know if you're still looking at the chats, but lots of people are giving you kudos.
Well, thank you very much, everyone.
And here's Mary too.
Yeah, I couldn't figure out how to get back into being able to talk at the
Oh,
end.
sorry.
No, that's good.
That's me. I should
Okay,
have
no,
I
that's
should have let
okay.
you back in.
No, that's all right. I just wanted to.
I think you guys were muted again.